Well, hello everyone. Hello, hello. Welcome to our great community, our RaySearch webinars. Very happy to see you again for another session, for another webinar, and for another episode in our very newly launched series about adaptive online adaptive radio series that we call Adaptive Care Your Way. So we launched it a couple weeks back. I promise that it's not gonna be the one-time, one-hit wonder with only one episode. So we're continuing the series, and today we're continuing with the second episode, which will focus on the workflows and how do we reach a higher levels of integrations to enhance support and improve online adaptive treatments, and honestly make it more approachable, accessible for patients that are in need. So very welcome to our episode. And so what do we have today? So today we have two lovely presenters from our very well known, at least for research, clinic located in Belgium. So representing Belgium today and Iridium Network, we have Geert. Hello, Geert.
Hey,
And Geert is joined by his colleague Joachim. Hello, Joachim. Right. So these are two presenters that will. Hi, Joachim. Nice to see you. So Geert and Joachim will share their experience with online adaptive treatment and how do they reach milestones that were needed for enrolling and starting online adaptive program at their clinic. I think it's a very timely scheduled webinar, and I let the presenters talk more about that. But we also have more people behind the screens, and let's see who they are. And they are our in-house experts, as we call them. So these are research experts that have been involved with online adaptive and a whole bunch of other development solutions that we have here at Ray. With wearing a mask today, but that's Tina. And let me assure you that Tina is the same person behind the screen who will be answering some of your questions that you're more than welcome to leave throughout entire presentation in the Q&A section. We also have Gunnar. Hello, Gunnar. Then we have B, our clinical specialist for RayCare, also joining us today. And finally, we have Dave. And Dave will take a bigger part in today's webinar because we received a lot of questions in the previous webinar and also throughout the registrations, and we hear it in the community that the interest is a lot about integrations and interoperability between different software solutions. And no wonder we also asked you about how many different software solutions do you use or you think you use in your radiotherapy departments. And I must say that 50%, so half of you said that you're using three or more different software solutions. So, and some of you, they were even using seven or more. So the interoperability possibilities are here, are present. And we as research would like to go forward a way where we only need to use ideally couple one software solutions because it's so highly integrated that you as a user don't even need to think about the back end of integration. So that's why we have here Dave today. Hi, Dave.
hi,
Uh,
Martha.
Hello. So very nice to have you here. And please share what is our roadmap thinking and the vision behind interoperability when it comes to our creating software solutions at RaySearch.
All right. Thank you, Martha. I will share my screen. All right. So as Martha mentioned, my name is Dave Stelpstra, and I'm the technical product manager for RayCare. I will shortly introduce treatment delivery integrations with RayCare and the machines that are supported today, but also the upcoming plans in relation to the support for online adaptive with RayCare and RayStation. So for quite some time, a couple of years already, RayCare is supporting the treatment delivery workflow with integrations to several machines that are used in clinical practice with RayCare. And the latest delivery integration that was added is with the Varian TrueBeam family. But of course, more integrations will be coming this year even. So our customers that are using these delivery integrations already benefit from a fully integrated experience with RayCare and also RayStation in combination with the treatment device, and where RayCare basically provides full workflow support that guides the user from the first consult through the treatment planning and then treatment delivery until follow-up. Now, at the end of last year, we've added online adaptive workflow support for the Varian TrueBeam. And since this week, it's even in clinical use at Iridium. And Geert and Joachim will tell you all about this workflow. With the support for online adaptation for TrueBeam via RayCare, we make state-of-the-art treatment possible for every patient in a fast and automated and individualized way. And there are a couple of key components in this online adaptive treatment workflow. First is the TrueBeam device. It's either the TrueBeam STX Edge or the VitalBeam. And this is providing the daily imaging and, of course, treatment delivery. Then we have the Varian treatment interface, the VTI. This is the scheduled appointment list for the machine, and it is used to select the patient's appointment and start the treatment session on the TrueBeam console. And all information that is shown in this interface is coming from RayCare. And it also displays for a scheduled appointment if the online adaptive procedure is required. Then RayStation, the automated replanning module in RayStation will be used to evaluate the scheduled plan during the online adaptive procedure, create the adapter plan, and when ready, assign the adapter's plan directly from RayStation to the active treatment session in RayCare. And then the last key component is RayCare, which is basically the orchestrator for the online adaptive workflow that connects all these components together. And during an online adaptive session, RayCare will support this workflow in the background as the RayCare application does not primarily need to be used by the RTT in the control room. And RayCare is doing this by managing the treatment appointments and the treatment course and with the to-be delivered fractions, but also providing the image and plan data from RayStation to the TrueBeam and vice versa. And finally, documenting the full adaptive treatment automatically in RayCare. So this setup allows for fast replanning while the patient is on a couch, while fully taking away the need for manual transfers between the systems. So what's next then? So this year, we will be adding a standard treatment interface in RayCare to support the treatment delivery workflow according to the TDW2 profile. And for those that have not heard about this before, TDW2 is the second version of the treatment delivery workflow profile from iHero. And iHero is an initiative by radiation oncology healthcare professionals and vendors to develop profiles that promotes optimal integrations between multi-vendor systems addressing clinical needs, such as this case, an optimal treatment delivery workflow. So this standard interface allows any treatment device that's compatible with this TDW2 profile to integrate with RayCare more easily. And besides some of the existing treatment interoperabilities that RayCare already has, there are already other machine vendors lining up to start using this interface later this year. next year. And a few of these machines are for example, the PCure, the BABIC, and the Mavion Fit. So from next year on, we are planning to add online adaptive support for this specific standard interface. With that, we're making state-of-the-art online adaptive workflow also available for a lot of more machines. And during Astro, you will be able to see a demo of proof of concept for this with the Leo Craze machine for upright treatments. And you can visit us there also at Astro at the RaySearch booth or the Leo Cancer Care booth to book a demo to look at this demo. So in parallel, there are already several collaborations ongoing with machine vendors and clinical partners to look at the full online adaptive workflow, which will then also result in added support in the future as well. And finally, RaySearch is, of course, also actively contributing to iHero, and we will adapt to new or updated profiles related to online adaptive when they become available. So that's it for me. Back to Marta.
Great, Dave. Thanks so much. I'm just the person who's happy to see slides and then the radiotherapy and cancer care in general. So I believe that this standard interface approach will streamline a lot of these bottlenecks when it comes to interoperability and online adaptive becoming an accessible treatment approach for many more clinics. So thanks for that overview. That is great.
Okay.
And let me again use this opportunity to remind everyone that if you have any questions, we do have Q&A section open throughout entire presentation and throughout entire time that we have any of our presenters with us on the stage. So please use that. And with that said, let me move over to our colleagues, I must say, colleagues in a way that we are collaborating together with Iridium for many years now. And this time, let's talk more about their efforts in scaling adaptive treatments through software and connecting that to one of the machines that they've also covered in more detail, so TrueBeam machine. So I believe we'll start with Geert. So stage is yours, and Joachim will follow you after you're done with your part. So good luck, Geert. We're waiting here to hear more.
Okay, thanks, Marta, for the introduction. Normally, you can now see my screen. So indeed, we were asked to explain a little bit about what we're doing. We will not spoil everything during this webinar. If you were following your social media today, then you probably saw things passing by about us and some milestones regarding online adaptive. But all that detail, if you want to know more, then I will already invite you for the Astro RaySearch Lunch Symposium on Sunday. But today we focus a bit more on the background and about all the preparation work that we were actually doing the last couple of months. So first, I would like to start with going back, I think, 2 weeks in time to the previous webinar about the adaptive care. And there were 2 very nice presentations of Alex and Rune. And I think the main message was very important. It was start where you are. But on the other hand, I also noticed a few, call it limitations or drawbacks, despite all the possibilities, mainly all the workflow handling, all the data transfers within their setups. Setups were impressive, but still a few things could be, at least in my opinion, a little bit faster. So if we go back to start where you are, then I will first have to explain a bit where I am today. And so I'm Geert, a physicist in Antwerp working for the Iridium network. And on the right-hand side, you actually see my department summarized in half of a slide. And actually, the most important thing is that today we only have TrueBeams in our department and 2 CT scanners. And with that equipment, we treat over 6,000 treatments a year. But actually, the most important part is here at the bottom. And as a department, a couple of years ago, we decided to switch gear a bit, and we picked a few, I call them key partners. And we work together with these partners, trying to make radiotherapy in our department as efficient as possible. And it will not be a surprise that for the software, we rely on RaySearch, RayCare, RayStation, and other things. But also important, even in this story today, is that for the surface scanning, we have CRAD on all our Linux. For the QA, and here I mean both machine QA and patient QA, we rely on Sonuclear. And the machines, as already said, we have 10 TrueBeams, so they are all Varian. And having said this, where we are, maybe you know, but for us it started actually in 2018, and actually a little bit earlier. I think it's now 10 years that we are collaborating with RaySearch on the RayCare product. But in 2018, I think it was a couple of weeks after the first release of RayCare, it was RayCare 1, we actually went live with that version. That was a fantastic and challenging period in my professional life. But actually, 6 years later, it was followed by a second milestone, and that was in September 2024, that we delivered the first treatment of a plant-creating RayStation delivered through RayCare, but on a TrueBeam. And that was, again, of course, a very important milestone for our department. And if you look at the change that we implemented 1.5 years ago, this is actually one of my favorite slides with a very simple question. Look for the differences, because this is, to some extent, the change that we implemented. Of course, if you install RayCare instead of ARIA, more things change in your department. But on the TrueBeam, this is a very nice example of how software, to some extent, can impact or impact not at all your department. And I will not go into the details, but as you can see here, differences are small. And if you really want to know what is what, then I can tell you that on the left-hand side, you see a TrueBeam, which is connected to RayCare, and on the right-hand side, you see a TrueBeam that is connected to ARIA. And the differences are small. But if the differences are small, then it's very hard to talk about online adaptive, because with ARIA, to my opinion today, that is not possible. So what is then the real difference between these two screenshots? Well, the main difference is that today in our department, RayCare is at the core of what we're doing. It's connected to our hospital information system to get in some key information, but it's also connected to our surface scanning system, QA system, everything controlled with scripting, and in the end, of course, very important, also connected to the TrueBeams. So now going back a bit in time again, going back to September 2024, because that's the day that we started delivering treatments on our STX machines. And to be clear, RayCare today is connected to 2 Linux out of 10 in our department. And we started with just one single delivery on day 1. But if you sum up what we did over the years, you see that, and the data is from, I think, from last week, we delivered over 8,000 fractions today already with RayCare. And that's also a nice achievement. The 10,000 fractions are coming close. And actually, these numbers, they made us think actually already on day 1, because if you look at this slide, but also if you follow the previous webinar about the automation tools in RayStation, also we at Iridium, we realized that if you have RayStation, and RayStation has a lot of these building blocks like deformable registration, dose deformation, and stuff like that, and you have now also your TrueBeam connected to RayCare, then potentially 1 + 1 = 3 in this story. And of course, not only we realized that, also I think RaySearch realized that there might be some potential here. And this is what happened only just a couple of months later, because on November 1st, 2025, RaySearch was visiting us, and not only just visiting, we were doing some exploratory testing on how TrueBeam would react to changing plan updates in a way. And the fantastic thing is that only 1 month and a few days later, RaySearch was back in our department for second visit, a second testing phase, where we actually were already testing some integrations, some flows on test to evolve. And at that moment, we also knew that the moment we were upgrading to RayCare and RayStation version 2025, that there would be a potential to actually start looking at adaptive radiotherapy with these tools. So maybe not on November the 1st, but at least close to that period, we were not only supporting RaySearch in trying to making adaptive workflows working with our TrueBeams, we also started with preparing all the offline stuff on how to actually adapt plans. But that part will be covered by Joachim in the next part of this webinar. So diving into the details of the workflow, and as Dave already said, RayCare is an important part of it, but it's also a lot in the background. So you actually don't really notice that RayCare is working behind the scene, because if you want to do adaptive with a setup of RayCare, RayStation, and TrueBeam, in RayCare you only have to do one little thing, and that is selecting a radio button to say that yes, this patient will need for this treatment an online adaptation. And if you do that, then in RayCare, actually all the work is done. And afterwards, you can just go to the LINAC and do all your work that you do as always, setting up your patient, acquiring a CBCT CT, doing your registration, and then actually the adaptation process starts. And here, as Dave said, RayCare is handling the connections, the data transfers, but actually because the moment you have your image and you have your registration, you can actually send the data to RayStation, follow the adaptation workflow. More details will follow later. And when you're done and you're happy with the adapted plan, you just send all the updated information back to RayCare, and you can actually open a new session with the adapted plan available now for treatment. This sounds very familiar to what you saw in the previous webinar, except a few things. And these few things are, of course, on the RayCare side. And a big change is that RayCare is working in the background, but working very efficiently in the background. It's a bit like, in this case, RayCare is watching you, because the moment you are in an adaptive track, RayCare knows it, RayStation knows it, and if you open up your patient, and RayCare, they start listening for new data to come in. In this case, it's a registration file and a CBCT. And the moment that data is sent from TrueBeam to your RayCare system, RayStation knows it within a second. And you can just import your CBCT of that day and initiate the entire adaptation process. At the end of the process, you have to approve the plan if you're happy with the adaptations. And also here, it's not really a lot of work. You have to check a few settings. You have to define what DICOM location your RayPack system actually is to handle all the transfers. And you have to enable an auto export, which means that the moment you approve your plan, everything will be exported already to the RayPack system. So then it will become ready for treatment. And then you have to hit one final button and actually to assign your plan to your treatment course. Because we make use of the RayPack system, we can also use the automation which is in there. You can use some rules or some scripts to further automate data transfers. We use this already for CRAD. We are going to use this also for our QA system, for some nuclear. And what we actually try to aim here with these automation exports is that we don't have to do a lot of things manually, of course, but we also try to keep working with our current systems the way we do today, which means that we will still try to use some nuclear as a QA system. Pre-treatment QA in an online adaptive setting is, of course, difficult, but we're still using also EPIT in vivo dosimetry So that's something that we can still use as a QA system. And also CRAD, we try to use to monitor the patient to see that the patient is not moving during the time that we are actually adapting the plan. But very important also here to mention is some timestamps, because people often are very concerned about how fast is the online adaptation. Well, the good thing is that because RayCare is working continuously in the background here and waiting for input, your import of your CBCT in RayStation through RayCare takes only 10 seconds. And I think that's quite fast. The plan approval takes more or less 30 seconds, but within these 30 seconds, your plan will also be exported to the RayPack system. So it's already then available for TrueBeam, or almost available for TrueBeam to be loaded onto the machine. And another very important button is actually the button to assign your adapted plan to your active treatment course. And this is actually a 0-second click, because it's only one click, so it's maybe 0.1 seconds, because you still have to click the button. But by doing that, RayCare knows what you want to do, and all the information in the OIS will be updated, and your plan will be ready for delivery. So in summary, I think it nicely shows that with the workflow I'm explaining here is that the integration is, it's fast. It's also safe because it comes like some kind of a package deal. RayCare, RayStation, and TrueBeam, all the connections are validated. I see it as one ecosystem, so you don't have to take care of all the connections and safety checks because they are validated the way they are installed in your department. And also, if you look at our solutions sometimes, and certainly with these manual things, then the administrative work is quite a nightmare. And also here, actually, all these things, they can happen in less than a minute. So with this setup, you just have to focus on adapting the plan, and you don't have to focus on preparing your plan for adaptation and making sure that all the approvals are done and that all the checks are done. So what are now the challenges, at least looking at the workflow? I think the challenges today we still have is all the third-party interfaces. The integration between RayCare, RayStation, and TrueBeam, I think that's working very nicely. But still, both CRAD and also Sonaclear, it's working. We're using it, but it can improve. Discussions are ongoing, so we will see what can improve in the future. But I'm looking forward at least to some upcoming releases of these softwares as well. And another challenge is, and that I think a lot of people are struggling with that if you're doing online adaptations, independent of which system you use, is about the roles. Who will take responsibility for what, and how do you don't, and you have to be careful that you don't end up with 20 people at a console, because all these people, RTTs, RadOncs, and MPEs, they are responsible for different steps in the workflow. So you have to come up with a nice way of making this as efficient as possible. But to conclude my part of this webinar, I think, the previous speakers, Alex and Rune, were right. In a way, you only need a workflow. And Alex really nicely showed that you can come up with workflows that actually work for Elekta, for Accuray machines, and even for Varian machines. And you only have to tweak these workflows a little bit because in general, there is a lot of overlap between all these flows and processes. And also Rune nicely explained that with Elekta, you can actually do a very nice adaptation work. And as I presented it here, you just save some time. It's nicely integrated if you go for the RayCare and RayStation integration. So yeah, this is my conclusion. You just need a workflow and of course some good software to handle it. And with this, I would like to hand over the floor to Joachim, and he will now explain a bit more the details and the configurations within RayStation.
Yes, thank you, Geert. So the idea behind my presentation is to give you more details about the workflow. So to really walk you through the workflow step by step. But first, a few words of introduction. So I will not present our center again because Geert just did it, but he didn't mention one thing, is that we will have 2 new machines coming this summer. So we already have 10 Linux. I'll let you guess what machines are coming. TrueBeams as well. So yeah, we are very much fan of TrueBeams, and I will go back to that at the very end of my presentation because those machines are TrueBeams but with a twist. So the idea behind online adaptive radiotherapy is to adapt the plan when the patient is on the couch. And this idea is actually not very new. It's quite an old idea, but it's only recently that it has been made possible through technological advancements. And the way I see it is that you have on one hand imaging-related advancements, like MRI Linux, higher, better quality CBCTs, and on the other hand, the more computer advancements, GPUs, AI, new dose calculation algorithms, SCTs, etc. And at the intersection of those emerged online adaptive radiotherapy. And since the early 2020s, you have some vendors that propose their solutions, and most of them are integrated solutions. But we at Iridium thought the imaging and the AI GPUs, we already have them, so why not use what we already have? And that's why we chose for the RaySearch solution. And the first indication for that, we thought about bladder because bladder has a lot of daily variations. So we had a look at 200 pelvic CBCTs, and we found a median variation of 35% in volume with respect to the planning CT. And it's also quite a simple plan because bladder is just a sphere, basically. So it's not the most difficult plan to make. So that indication would actually benefit a lot from online adaptive with not that much effort, we thought. So that's why we chose that as our first candidate. There already exists a lot of volume mitigation strategies for bladder. There is here a relatively recent review. And there are 2 main strategies that they found. It's online adaptive and plan of the day. There is a dosimetric benefit, and the potential for clinical benefit still has to be proven. There are 9 ongoing trials I know about in the world. Maybe there are more, but yeah, this has yet to be proven. And in 2025, at Utrecht, they performed online adaptive on their C-arm Linac. So we thought, okay, why not us? So let's walk you through the workflow. Those numbers, the timings I will mention, come from a feasibility study because our clinical experience is very recent, very new, so I cannot say anything about that yet. So let's work through it. First, let's have a look at the offline adaptive radiotherapy workflow. So you are probably familiar with that one. It might be very similar in your department as well. We start with the simulation and the registration of the images. Then the radiation oncologist will contour those images. Then it goes to the planning. The plan is approved by the radiation oncologist, finalized. Then we perform some pre-treatment QA. The plan goes to treatment approval. It gets a final approval by the radiation oncologist team, and then we can proceed to the treatment. Then during the treatment, we will check the dose with in vivo dosimetry, and if needed, we can re-simulate the patients and start again from the contouring phase. And if not, we can just proceed with the same treatment. For online, it's actually quite similar, except the patient is on the couch, and we've developed a detailed map of the workflow. This one is really detailed. You can see the colors. Each color corresponds to a task. The RTTs, the radiation oncologists, the physicists, and the gray is the automated task. And yeah, almost every click actually is represented on that one. So it's important to do so. It was the basics of our FMEA analysis. But for this presentation, I will focus on the core of it, so the RayStation part really. And the RayStation part starts with the import of the CBCT into RayStation. Then you can hit start in RayStation. The synthetic CT is created. The organs and the target are segmented. Then the scheduled dose is computed. The new plan is created with the adapted dose computed on it. And then you can start to perform some manual adjustments. You review the SCT and the region of interest. And then you can already make a first decision about the base plan. If it's okay, you can deliver it. You can choose not to adapt. And if no, you can go to your adapted plan, tune it, maybe perform some more rounds of iteration and of optimization. Then you will QA your adapted plan and deliver it. So the blue blocks here are actually what's happening when you hit start. So you don't need to do anything with those steps. It's automatized in RayStation. And the green blocks are mostly humans' decisions or interventions. And those manual adjustments, you need to go through the whole workflow before doing them. So that's a limitation, but it's been handled in the next version. So we are also very excited about that in version 2026. And that's what it looks like in RayStation. So we have this start button, synthetic CT, structure, scheduled, adapted, and approve. And each of those steps, you can tailor them by using the planning protocol. So maybe you are already using planning protocols, if in your offline adaptive workflow maybe, or just in your normal planning, sorry. And here for online adaptive, there is a small difference, is this button. So you have to check use for automated replanning. And you also need to create a synthetic CT. That's not needed for a normal planning protocol. But apart from that, it's really similar to something you already know if you are a RayStation user. So the first step is the CBCT imports, as I was saying. And for this, when your TrueBeam is connected to RayCare, like we did, it's really straightforward because you have this import button and this pop-up that shows up when you start your session. So RayStation knows that you are in an adaptive session. It expects an image and a registration. And as soon as you hit save on the TrueBeam, after performing the registration, this will pop up and you can just import the images. And it takes it. Then we have this little script that we use to adjust the name, to add the coach on the CBCT, to assign a density. And it lasts up to 5 seconds. And all those changes are mostly for our QA part. The only very important step is to assign the imaging system, because without that, you cannot create a synthetic CT. But the rest is mostly our choice, because it will be important for us for the QA part later. Then we will create a synthetic CT. There exist two algorithms in RayStation. You have on one side the corrected CBCT, and on the other side the virtual CT. So the corrected CBCT works through an iterative process. It consists of conversion of the Hansby unit and a low frequency artifact correction that are iterated over. One limitation is that it depends on your CBCT quality. So if you have big artifacts, sometimes it's difficult to get rid of them, but it's always a good representation of the anatomy. So if you have hair pockets on your CBCT, you will see them in the corrected CBCT. And conversely, if you did have air pockets in your simulation, but you don't have them in your CBCT, you will not see them. The virtual CT, I like to see it as a smart deformed CT. So the CT is first deformed to the CBCT, and then it also creates a corrected CBCT under the hood, and it uses the values of that corrected CBCT where large density gradients are detected. So typically wherever you have air pockets. So the Hounsfield units are very accurate because they are just those of your CT. But the limitation is that it's very much dependent on the quality of the image registration between your CT and your CBCT. So we chose to commission the corrected CBCT algorithm. And yeah, to create a synthetic CT, it takes up to 30 seconds. So we've commissioned a corrected CBCT algorithm by doing some tests on the CAT phantom, on the Sears phantom, and then on a small cohort of 10 patients. So as you can see here, we found absolute difference in Hounsfield unit ranging from 5 to 46 Hounsfield units. And that translates to dose difference of 0.1, 0.15%. So it's acceptable. We judge it acceptable. Then the third step is the segmentation. So our segmentation strategy consists actually in 3 different steps. So you have first the organs at risk in the bladder segmentation. Then you have a deformable registration with the bladder as controlling ROI. And then the target is propagated. So as I said, you can, this is our strategy, but you can actually define your own strategy. And this is defined in a structured template. So it looks like this. Maybe also you are familiar with it if you use structured templates for your contouring in RayStation. So you can define whether you want to segment those organs with rigid mapping, with deformable mapping, with the option of using controlling ROIs. So controlling ROIs are actually regions of interest that are segmented on both your simulation CT and your corrected CBCT, and they will be used to guide the deformation. So if you are a ETOS user, it's really the equivalent of an influencer organ. And of course, you also have derived structure, like algebraic definitions such as the PTV, for example. It also takes about 30 seconds to run for those organs. And as you can see here, we can have different results. So what you see here is a test for prostate using different sets of controlling ROIs. And you also have some sensitivity to artifacts. So maybe you want to define a strategy that's more robust, as you can see here on the bottom right. So we conducted a little study to select our strategy. We've compared different strategies. Here you see AI and deformation. And for this case, we didn't see a lot of difference. So between the corrected contours and the initial contours, we calculated the dice score and the Holsdorf distance, and then we compare those between those 2 methods. And for the male, we don't see a big difference. For the female, however, we see that the deformed strategy performed a little better. And it makes sense because the pelvic model is actually trained on male. So in that case, yeah, it was more recommended to use the deformation. For the propagation of the CTV, or for the segmentation of the CTV in general, we also compared the deformation and the DLS segmentation. And we found that for the DLS, it will, in some cases, like here, the radiation oncologist will choose to incorporate some additional parts in the CTV. So what you see here in yellow is the bladder as segmented through DLS, and in pink is the CTV. And you see we have this bottom part that was not in the DLS. And of course, if you deploy DLS on the corrected CBCT, it will do the same. It will not include that part. But if you do a deformation using the bladder as a controlling ROI, then you will actually be robust to those little changes that the radiation oncologists like to make. So that's why we choose to propagate the targets using the bladder as controlling ROI. So that leads us to our fourth step, the scheduled dose computation. This one is really straightforward. It's just the anatomy of the day. So you have the anatomy of the day, you compute the plan on it, and then you can look at the clinical goals and already make a first decision if your organs are okay, of course. And the computation time is about 45 seconds for that. And finally, we have the adapted dose. So a new plan is created. And for the optimization problem, the objectives and the constraints, they can either be loaded from a template, they can be copied over from the base plan, or you can do both. You can copy your objectives and then add some new ones, especially for the adapted plans. They also can be manually adjusted if needed. So in some workflows, the adapted plans, you have to accept it or not. In this case, you can still tweak it. You can do some final iteration rounds. You can do fine tune. So all the tools that you are used to in RayStation. And it also takes about 2.5 minutes to have a plan ready. So you can define those steps in this apply optimization setting step. So one of the most important is the max number of iteration, because that will limit the time it takes to generate this plan. And you can also add multiple of those. So in our case, we do a first round with a maximum of 40, and then a second round with a maximum of 20. And this is what our template, our objective templates look like. As you can see, we use a lot of those follow-ups. And the reason behind it is that in online adaptive, you don't want to use too much objectives that are dependent on the volume of your organs, because they can change from a day to another. So that's why those follow-ups are recommended for your template. So if we sum up the timings, we had 10 seconds for the CBCT import, then our preparation scripts, the synthetic CT creation, the segmentation, the scheduled dose computation, the adapted dose, our QA script. I will go back to that later. And that sums up to 5 minutes 30. So I repeat, this is the feasibility study, and it has been run on NVIDIA RTX 6000 GPU. So of course, it also depends on your hardware. And there are, of course, in the clinical reality, there are also manual adjustments that you need to take into account. There are the contours. We also conducted a small study on 60 corrected CBCTs, and we found out that our radiation oncologists were very fast for bladder. They take a median time of 5 minutes. It ranges from 3:30 to 5-6 minutes. Then you have the adjustment that you want to make to the plan. We can add an additional 2 minutes for that. On the machine, you also need to acquire the CBCT and perform the matching. It's also 2 times 4 minutes 30. And you have also the import in our SGRT system, 1 to 2 minutes. So it sums up to about 25 minutes, 26. So we wanted to see if it's doable within 30 minutes, and it is, according to our studies. So now, as I said, we are entering the early phase of clinical experience. So we'll see how that translates into real clinical experience. So I was saying we have a QA script. So I will talk about it with more details. So first, we export our plan to our QA platform. So as Geert said, we use some nuclear. There, we perform the secondary dose calculation, but we do it while we are actually doing the rest of the adaptive steps. So we don't actually wait for it, otherwise it would take too long. And we also do in vivo transit dosimetry. Then we have this in-house QA script. We check the CBCT acquisition time. So if the CBCT has been taken yesterday or like too long ago, then it will flag a message. We check the differences in monitor units. We check if there are any overrides, and if there is a mismatch between those overrides. So if something was overridden in the CT, for example, and not in the corrected CBCT. We check the differences in region of interest volumes, in Hounsfield units, average value, in center of mass positions. And then we compare the dose on the CBCT and on the corrected CBCT. So as I said, with this preparation script, we assign a density table to the CBCT. And that's something we use afterwards here for the QA script. where we compare the dose on the native CBCT, let's say, and on the corrected CBCT. And we use for that the gamma analysis and the DVH differences. And it also comes from a little study that we did. We took 50 CBCTs. On one side, we computed the corrected CBCT. On the other side, compared the dose. Then we introduced some errors, some kind of special prothesis that the corrected CBCT could not really deal with, and also an incorrect external segmentation. And we found that those errors nicely appear as outliers in this distribution. So it really gives us trust in this query process that it's a good way to check if your synthetic CT has been correctly generated. This is just another way to see it, a use case. So for a patient, we had on fraction 7, very high values for those differences and very low value for the gamma. And we had a second look at it, and we saw that the synthetic CT looked very strange. And this was due to faulty external segmentation on the CBCT. So in that case, it's actually both the CBCT and the synthetic CT that are not correct. But by comparing the dose, you can still notice that something is not good there. Then finally, I would like to have a few words about dose tracking. Why? Because when doing online adaptive, you get the corrected CBCT, the contours, the dose. So you already have all the ingredients, or nearly all the ingredients to do dose tracking. You are really one step away. So this is why the dose tracking interface looks like. On the right-hand side, you have the treatment course. In that case, it was not an adaptive course. It was just a normal prostate case that we monitored with dose tracking, that we followed through the treatment. So as I said, in the online adaptive workflow, you already have almost all the ingredients. You just need a deformable image registration between each of the corrected CBCT and the planning CT. In that way, you can perform dose accumulation, and that can be scripted. And if you are connected to RayCare, then the delivered plans are automatically assigned to the corresponding fraction. So this is what it looks like in RayCare. If you start the adaptive workflow, when you hit this button, so here it tells you that the treatment course is not synchronized, but then if you hit that, it will detect in RayCare, okay, this fraction has been adapted with this beam set and so forth. And then you can do dose accumulation. And we also did a small study on 10 prostate patients where we did the accumulation and we looked at the dose variation on different organs. Yeah, here is the legend. And we saw a lot of variation if you looked at the fraction dose, which may be concerning. Say, oh, we are really, maybe we give it too much dose on the rectum or having some under coverage. But when you accumulate, then you realize that those variations, they kind of compensate each other. One day you can give a bit more, one day a bit less. And when doing the accumulation, you realize that you are actually very close to the planned dose. That's actually what we saw for these cohorts. So of course, we still have to look at the uncertainty of the deformable registration and those things. But I think it was a nice first study, and it shows that those online adaptive and leads to dose tracking, and dose tracking open the doors for exciting applications. So what's next for the future? Well, we are doing a study on SIM-free radiation therapy. So we are planning on the diagnostic CT and delivering the plan, so without any simulation, for palliative cases to reduce the hospital time. The next step for this study is to correct the dose with the dose on CBCT, so to combine SIM-free and online adaptive. Then we will look at other indications like prostate, for example. And those new machines that are coming this summer, I was talking about at the very beginning, I said they have a twist, and this twist is HyperSight. So the promise of HyperSight is to have a better image resolution and a larger field of view. So hopefully that will open the door to other indications like gynecologic patients, head and neck offline adaptive directly on CBCT, and so on, probably more. So the story is to be continued at the lunch symposium at Estro. Geert will talk a bit more about the clinical experience. So that's the end of my presentation. And if you have any questions, feel free to ask.
Great, Joachim. Thank you so much. And I love that you end your presentation with a carrot, with a little cliffhanger of where to find more. But already now and today, I believe we received a very detailed, but I think digestible way of showing your workflows and your approaches. So there were a couple of questions in the chat. So you're more than welcome to leave more questions there, or some questions that we can also come back later in our emails. But there was. So I love, and I think I'm not the only one who likes seeing numbers. And these, as Joachim, you did the feasibility studies, right? And then, so your projections would be that online adaptive session is possible to do under 30 minutes, right? You said something about 25 to 26 minutes. And so we also asked a similar question to our audience while they were registering. So we were asking what you consider an acceptable timing for a single online adaptive session for it to be useful and viable for patients. And 63% of registered people, and probably many of you are here on the call with us today, said that it has to be less than 30 minutes. So now by seeing this feasibility studies and tapping into more of that clinical rollout, Joachim or Geert, both of you, if you can come back to us and to join the stage, do you think it's doable? And you agree with 63% of people on this call that it should be under 30 minutes?
Yeah, it should be as fast as possible. I think if you look at the preparation work, the limited experience, but at least it's experience that we have today, I think it's definitely possible. The main question will be what do you define as the adaptation time? Is it the time you have to spend in the bunker, or is it really the adaptation time? I think the adaptation time between the end of the TrueBeam CT acquisition and the beam on, I think that is feasible. Let's aim for 15 minutes. I think 20 minutes is more than realistic, but 15 should be the goal. And for me, the in-bunker time of the patient should be 30 minutes. That's what we have to aim for. And I think we are very close to that.
Definitely. And then looking at your workflows, that's another question that I'm always curious about is that would you see, so where's the biggest potential to streamline the workflow even more? Is there a place where we can push a little bit more to reduce these seconds even or minutes?
And with you mean you as RaySearch?
As the community, that could also be RaySearch. Well, talking about RaySearch, I can say one thing. So I've noticed that you were doing the female and male deep learning segmentation comparison, and then for female, it worked to go with the deformed. So just for everyone here to know, the next release of RayStation is coming with the deep learning segmentation model for female pelvis. So to answer from RaySearch's point of view, this is definitely one of the areas where we can push for reducing the seconds.
Yeah, that's very nice to hear. And to answer your question, so something I didn't mention actually, and it's quite important to be mindful about the objective templates. When you are creating the adaptive plan, they start from scratch. So you are like using the same template, but it's like you're pressing start in the optimization and not continue. So to streamline the workflow even a bit more, we could use the knowledge that we have because we have some previous knowledge about the optimization problem. So we could use that to have even faster optimization step.
I think in the RayStation user community, it's known as the soft start, right? Or in the optimization. Yes. All right. There's one question from Jade, and I think it's for Joachim, for you, and it's about the usage of corrected CBCT versus virtual CT for your study. Would you like to elaborate a little bit more? Why did you choose corrected CBCT?
Yeah, it's mostly so as I said, the virtual CT it's dependent on the quality of the deformable image registration between your CBCT and your planning CT. And we've seen that for large volume difference, it can be. And for bladder, typically we have very large variations, as I said, up to 35%. So we've decided that for that case, it will be better to commission the corrected CBCT.
Definitely. All right. So I'm a time checker here now. That's one of my tasks as a moderator, and it's a few minutes past 5. But we're not ending here. Well, today we are sort of, but I will just like to take this opportunity and add on Joachim's and Hert's already mentioned activities that are soon to take and break the digital wall and actually come to Stockholm, so the home of RaySearch. So it's I'm talking about Estro. It's very soon, a few days only left. And at Estro, we are hosting this year a lunch symposium, and we are dedicating that symposium to no wonder what topic, online adapted. And there we will have our CEO and founder, Johan Love, joined by Susanna Lallentrelle from Royal Marsden and by you, Gert. So we'll see more of you. And then I believe this journey and your experience that you shared already with us will be continued in the live symposium with very exciting, huge milestones, not only for Belgium, not only for Antwerp, not only for Iridium Network, but I believe for the whole community of radiotherapy oncology. So yes, so please come join us in Stockholm if you're there, and if you're there, join us at our booth as well because we are having plenty of presentations, panel discussions on various topics that are also hot in the community, and these could be AI governance, also adaptive from more the clinical, and also trying to answer the question when to adapt. And then also about standardization of cancer care versus where should be personalized, and many other things that they are waiting for you at RayHub. So if you're there, please come join us. For anyone who are not there here in Stockholm for us, we will record some of the sessions, same as this one. So you will find everything on our YouTube channel. So for now, once again, thank you, Gert. Thank you, Joachim. Thank you, Dave, as well, who presented and been with us. And see you next time in the RaySearch webinar.